All right, so we're going to close it up with Phil Polgreen. I got him to come in and be our closer for the conference, give us a summary. So here it goes. Phil Polgreen is from the University of Iowa. He's also the director of the Infectious Disease Society of America's Emerging Infections Network, a CDC-sponsored sentinel surveillance group. In addition to traditional hospital epi, his research interests include developing new ways to aggregate information about infectious disease. He's been working on this area of prediction markets that you may be aware of, and applying quantitative methods to help prevent the spread of disease. He's currently working with an interdisciplinary group of researchers to apply quantitative approaches, social networking, time series methods to understand and solve the problems in the infectious disease world. So I'll introduce Phil.
Thanks, John. Mostly I still see patients, and I have a lot of great students that I get to work with, like Alessio, and it's a lot of fun. But my main job is seeing patients, and so John asked me to summarize this conference. And it was my own fault because I said that I know this guy that can do a really good job at summarizing conferences, and thinking that he'd pick that guy. And he said, well, why don't you do that? And I said, well, there are two things. The main thing is I'm not funny. And this guy's funny. And then he said something about my looks. No, I'm just kidding. All right, and let's see. It's up there. Okay, so this is, I don't have a title of this conference. It's called Conference Summary. And so I was going to just sort of try to summarize everybody's talk, but I got scared. So I had a crutch. And I thought, well, I see patients, and sometimes we talk about cases, and we do postmortems, and we go back and look at an accident or a series of events, particularly in one patient. But let's try to do this in an outbreak. And this is an ancient outbreak. It happened in 2005. So it was before, that was a joke, it was before a lot of this social media stuff was around. And what I'd like you to do, if I do the right thing, if I do an okay job, you'll listen to the story and you'll say, wow, a lot of this stuff might have happened differently if we'd had some of this stuff that I heard about in the last day and a half in place. Maybe things could have been different. So really, it's not to sort of say, oh, wow, all these problems should have, things should have happened differently. But what my goal is to think about, how can this be different in the future? And so I'm going to start with a patient. And I didn't see this guy, and I think he's the index case, or one of the index cases, but I sort of knew him. But I was not directly involved in his care. But I heard about it because he ended up being my RA later. And I talked to him last week on the phone. He's a 25-year-old graduate student in 2005. And he presented with 2-3 days of fevers and chills and swelling in his face, maybe his glands, and he said they didn't feel good. He doesn't complain. He didn't want to go to the doctor. He finally went to student health. Didn't have any history, no exposures, couldn't think of anything. Shows up at student health. And they thought he had strep throat. But he was so swollen that they actually referred him to the otolaryngology clinic for the next day. Not next week, next day. But his strep test was positive. So he must have strep, and he got a shot of penicillin. And I thought, well, that's aggressive. Did you want the shot? Because it sort of hurts. And he said, well, I was afraid I wouldn't be able to swallow the pills. And I said, because of the pain? No. I couldn't get watered down. I was so full. So he went home, and no relief. The swelling continued. Discomfort increased. He was having trouble getting watered down. He couldn't swallow. So he couldn't sleep. So he showed up at the clinic at 4 in the morning and waited there. Finally, a nurse came around 6:30, and she said, what are you doing here? I have an appointment. And she said, when's your appointment? And he said, well, at like 10. And she said, no, it's not. It's right now. So she let him back, and he kept thinking, because the doctor said, maybe you're the first. But she was talking about the first person with strep and huge facial throat swelling, like this. So I'll show you a picture of him. He didn't take a picture of himself, but he showed me a picture of what he looked like at the time. And this is it. He actually said he looked like he weighed about 250 pounds, and he was having trouble swallowing. So this is what happened. The nurse let him back, and instead of seeing the medical students first, he saw the staff first. And then the students came in, and he soon went to this surgical intensive care unit, because when they tried to stick a laryngoscope down his throat, they saw something like this. Now, in the bottom slide, this is supposed to show you an airway, but you can see it's so swollen there's really no airway. He was very edematous. This isn't actually, this is taken from a series of patients that had a similar disease. You probably have already guessed it. If not, probably your neighbor has. But he had lots and lots of edema around the supraglottis and had trouble. So he was taken to the emergency room, and he remembers them saying, yeah, take him to the unit and bring the kit just in case. So he's whisked to the intensive care unit, and along comes infectious disease after they get a CAT scan, because he wasn't getting worse, and they gave him a lot of antibiotics, a lot of steroids. And then one of my colleagues, who's very bright, came up with a long list of, long differential, and talked about the importance of not missing stuff that's rare, that can present in an unusual fashion. And mumps came up, but, you know, his IgG was positive, and his vaccinations were up to date. So this was very unlikely. So you know what? He went from the intensive care unit home, because he was better, he didn't get worse. Bye-bye, he's fine. Comes back to the infectious disease clinic, and he was convinced at that time that he had mumps, because he started looking up on the internet, reading about it. But no one else was, except for one of the residents that had actually trained in India and had seen a lot of mumps. But it would be very unlikely. All right, so I'm going to fast forward. The next case that I'm aware of, again, I didn't see, but I talked to her last week. She went to a Halloween party. She was a nursing student at the time. And she went to a Halloween party on October 31st. And she reports a, quote, close contact with a male friend at the party. And she said, the next day he called her and said, did I get in a fight with a guy? Like maybe that guy in the gorilla suit? I don't really remember last night, but I'm really swollen, and it feels like someone punched me in the face. And indeed, he was swollen. So she went back, in retrospect. There was another guy somewhere, it's probably from Europe, and, or somewhere else, but that had mono. Frankly, a lot of people had been having mono in that fraternity house. But at any rate, almost 2 weeks later, she showed up in the ER. She had bilateral face swelling, a fever to 104. She was admitted for IV antibiotics and improved. Notice she had puffy skin on her chest, and you can talk to me about that afterwards, because that was a clue. And she thought it was weird. In fact, later on, she wanted to wear a formal dress and couldn't, because it was so... She had so much edema around her chest, even after the swelling resolved. All right, so let's fast forward to December 16th. The public health department had gotten several calls about clusters of parotid swelling. Actually 3, but all 3 clusters had documented proofs of 2 MMWR vaccinations and had negative mumps IgM. So that's the first antibody to turn positive, if you remember from immunology. And so, in some other cases, other things were positive, strep throat, mono, etc. Now, instructions for culturing mumps were given, but apparently it was just not thought to be mumps. In fact, not was actually capitalized in this message that went out to, in the Friday letter. Individuals who have had 2 doses of mumps vaccine who are ill with mumps-like symptoms and or parotitis are not, and it wasn't read, but it was capitalized, NOT, likely to have mumps. So why did this happen? That's, you know, that NOT. Well, it turns out it was referring to a recently published paper that was in a really good infectious disease journal called Journal of Infectious Disease. At least they never publish anything I submit there. And in this paper it said, mumps-like syndromes in MMWR vaccinated children and adolescents are often not caused by mumps. So it was really this article that generated a lot of the sort of kind of reluctance to consider mumps. And, you know, it's interesting because the same year, there had been over 60,000 cases of mumps in England. But yet, there was no note of that in the discussion section. Not at all. It was all about all the other viruses that could happen. It could be Epstein-Barr, parainfluenza, adenovirus, enterovirus, paravirus, HH6, HHV6. Yeah, Okay, so now there's a hero to the story. Her name's Jean Pottinger, and she's an infection control nurse at the University of Iowa. So she thought it was mumps because she said, you know, all these other things don't cause epi-linked cases. They're cases where there's an epi-linked, and she traced them back. And then she found a guy, a student, that had this swelling in his face, but also had orchitis. If you don't know what it is, you can ask somebody else in the room. But it's something you can't miss. And so she called him. The college student really didn't want to talk to her on the phone about this particular problem, but she talked to his mom. And she got to the bottom of it. And his mom said, you know, really, he's had his vaccines, And she talked to the physicians and the local, and she started tracking down other cases. And she found case after case after case after case. All right, so then there's a natural experiment. So there had been these clusters in a few cases, but then all schools were canceled and all students were sent home. But this was actually planned. It was called winter vacation and finals week. So everybody went home. The campus shut down. All three campuses of major, every college shut down. And then you can see the report of Friday letters. Have a safe holiday, nothing, quiet, quiet. Think about influenza, influenza. Then, in February, an increase in potential mumps cases in Iowa. Iowa is experiencing an increase in reports of parotid gland swelling with positive testing for mumps, IgM. But still, the message was IgM can react with other antibodies and may be a false positive test. Well, it is truly the most promiscuous of all antibodies and can cross-react, but they did find one case where there's a culture. Now, people in public health can't order the cultures, and it's really up to the physicians. And one of the real problems is people would see this case, they think it was mumps, but they wouldn't order the culture, and PCR was not available. So, again, the clinicians hadn't been selling cultures. So, then finally, a couple days later, there were laboratory-confirmed cases, several, and then on the 24th of February, there's a rise in significant cases among vaccinated individuals, and this was really the start of a multi-state outbreak. Now, it was interesting, because it's important to note that 90% of these patients at this point had been vaccinated, at least one, and a lot of them, too, had received 2 units of vaccine. So, the story was out. So what was going on everywhere else? Well, I'd mentioned this case in England, but again, it was the same college age group, but it was thought to be that, well, maybe it's because a lot of the cases in England had not been eligible for routine vaccination there. So the thought was, well, maybe this is really a vaccination issue in England. But actually in York, that summer, there had been an outbreak in a summer camp. And this wasn't published in the MMWR until February, which coincided with the realization of the Iowa outbreak, but that there had been 96% vaccination coverage in a summer camp. Someone with mumps from England came, I think a counselor, and had exposed these kids, and there had been several cases despite this really highly vaccinated population. So there was information that would have helped in New York, that would have helped other places, but it wasn't published in the MMWR until after this outbreak started. So then I looked at Promed, and indeed, if one had been on Promed, they would have learned a lot about mumps in 2004, but in 2005, there hadn't been a lot of postings. In fact, echoing something we learned about in this conference, the consequences of reduced MMW vaccination uptake was noted back in 2001. Okay. So ultimately, there are probably 6,500 cases of mumps in the Midwest. And there have been outbreaks around the world since, probably not related. There just continue to be more mumps. If you look at Promed postings, there are a lot more mumps cases, after outbreaks since than before. But really no one in Iowa had seen mumps. 30% of patients are asymptomatic, which really complicates things. And there's a long delayed incubation period. So it's really hard to kind of track all these things down. And a lot of people have subclinical illness, probably especially if they've been vaccinated. And they may present in a slightly different fashion. So they may not present. And if they do, adults are much less likely to have the classic symptoms than kids. Also, there was sort of this, what turned out not to be the case, but there was this sort of, it turned out to be a misconception that if the IgG was there, there was protection. And that really wasn't the case, but it was sort of supposed. And there was really a limiting of testing in general. And no mumps were, serologies were done, and there wasn't a PCR at that time. So it was really a perfect storm. And I'd like to think that maybe this would change because all of these communication problems at the patient level, the clinician level, public health officials and researchers, all this might change today. And I'd like to talk about is this isolated? Well, I thought I'd have to talk for an hour, and I actually have 3 or 4 other examples where I've talked to some people involved with a very similar story where people sort of just, it was one thing, another. This is not isolated. I hope, and I'm inspired by this conference, this has become less common, but I want to tell you this is not the only kind of case, and we could find several others. So I wanted to briefly summarize the conference. I just think I had to say a few things other than present this case. So kind of what I learned. Well, I learned that the crisis mapping may have been inspired by disease detection, but I think that, I think we could learn a lot from the Crisis Movement Project. And the idea of crowdsourced maps came up, and the real question is, can this be sustained? Can this be sustained beyond an outbreak? I think John asked that, and that's certainly something we'd want to try to do. And the difference and hope is that patients are increasingly informed. So, they're not really amateurs, and now they have, they've sort of resources that no one would have believed possible 10 years ago. More information than I did when I was a medical student. So my mother calls me last week or 1 week ago, and she said, well, I have a rash, I have shingles, I need the antiviral, I need it soon, because it won't work anymore. What are you going to do about it? So she had already made the diagnosis because she'd looked at a picture, looked in a mirror, she knew the treatment. She used to teach 5th grade. She had figured this out, she knew the timing, and she came in. Patients are incredibly informed now. And so I think the ability to capture some of this involvement and with the resources that they have, the potential is limitless. Okay, the second plenary, I really learned a lot from this talk too. The position of people in a network is really important, both from an informational standpoint and from a disease standpoint. Just think about mumps. All right, so when I went back and tried to learn a lot about mumps, I learned the most important lessons for mumps were in grade schools, military, and prison ships. And come to think of it, college dorms are really the new prison ships for public health. In fact, in post-2000 era, almost all outbreaks have been linked in one way or another to college students because it's a dormitory. You're bringing people that have not been together and been isolated all together in one small environment. All right, so what did I learn from the rapid talks? Well, these were great. They were all, I tried to do this in a theme way, but they were all sort of unique and contributed in a unique fashion. The participatory surveillance, for example, what a great way to get crowd involved and get people to volunteer information. The patient safety from Teresa's talk, I learned a lot about how photos could be used. And I thought that was great, the picture of the guy with mud on his tongue. And I was thinking about patient MK. What if he'd start sending or posting a picture of how swollen he was? Don't you think other people would look at that if that had been his Facebook page? I can't believe that it wouldn't be. Now, I think he would have posted it, but the nursing student, I asked her, and she said, oh no, I wouldn't. But I think there'd be enough people that would post it. Biocaster the talk by Mark Conway reminded us how important natural language processing is. Monitoring rumors and vaccines remembered what a timely talk this is. In fact, there was sort of monitoring of this problem back in 2001, and if we'd known a little bit more about this, and other people had known beyond Promed, or more people were reading Promed, maybe we would have, maybe this wouldn't have happened. Analytical methods for large-scale surveillance from Daniel Neal. I think we really need to think about new methods with more data. Predictive modeling. It was great to hear a talk about forecasting. When I first got interested in this, I was told by several people in public health that you can't forecast disease. But really, I was thinking about this, and if you've heard of, no one really makes jokes about weathermen anymore, or weather people. Because there used to be, growing up, it would always be a joke about the local weather forecast and how inaccurate it is. And no one really does that, and it's really because the data is better. And I really like this talk, Tiffany's talk, about trying to incorporate some of this new data to build better models. So space-time outbreak detection, the importance of finding the signal from the noise is so important. Risk assessment. I mean, wouldn't it be interesting to be able to figure out where college students go or where they would go? Indeed, this outbreak spread because college students and athletes, spring break, et cetera, spread throughout the Midwest. And wouldn't it be nice to anticipate and try to increase vaccination levels around the Midwest? I think we could do that. I was reminded of Damien's talk, the importance of One Health and the opportunities of social network to do this, and search query surveillance. Andrea's talk really reminded me of an example. It's how important it is to have an example of how these things really work. All right, so then Twitter, the panel, new data streams, perceptions, disease activity. At least we can measure one thing over time. The panel was very interesting, and we may not be able to measure something that's actually ultimately verifiable, but maybe it'll be stable, and we can measure that, and just that changing over time. There's some, Gunther brought up some important privacy issues that we need to explore. And I don't think, Twitter won't solve all the problems. I read this article in The Onion about how Twitter failed to solve this child's kidnapping. But I do think that, definitely social media, even with its limitations, which would have changed the course of this outbreak. I mean, new ways to communicate information. college students would have known a lot more what to look for. Anticipating measuring concern. Wouldn't it be nice to know about concerns for the vaccination effort? Evaluations of messages. Detecting new cases. And just to compare this, there was another outbreak that was detected by Twitter in Iowa. It was among the football team. And so what happened here is the athletes didn't go to their healthcare providers. They actually started tweeting it. And they started to tweet stuff like this: my urine's brown, and I really hurt. So what did they have? There's actually several cases of rhabdomyolysis. They'd gone back, the assistant coach really tried to get them in shape. And as a result, and they hadn't been drinking, and as a result, several of them a couple of them went to the hospital, and this is a potentially fatal condition. You can end up in the intensive care unit from this. Several of them had severe pain, missed parts of the season, et cetera. And it was really, they all had rhabdomyolysis. And any internist reading this Twitter stream would have figured this out. And, but they didn't go to the trainer, they didn't go to the coach, they went to Twitter. And someone in the local newspaper figured this out. All right, so this morning, what a great summary of rapid applications of digital disease data. And it's interesting, just in the last few years, to just wonder and learn about all these different new ways of aggregating information. What's so interesting is how many different people are doing it in different places, a little bit differently. And this is so exciting to see all the focus on information sharing across different groups. And I think InfluenzaNet, especially sort of echoed the promise of crowdsourcing some of this surveillance data. Mobile disease detection, well, an interesting panel. I mean, I knew that phones were ubiquitous in Iowa. These are two pictures that were taken in Iowa. This guy's on a swing set tweeting, and this other guy's in an unprotected, some sort of device watching a video while in a swimming pool. But it certainly, I knew this was going on in Iowa, so I had an idea that it must be ubiquitous. But certainly what I learned that it's really around the world and really a platform for learning about diseases, the importance of geography, doing surveillance, measuring health, and designing and implementing interventions to improve access and actually delivery of care. From the big data talks, well, there'll always be new sources of data. There'll be more than Twitter. There'll be the next Twitter. And there are always needs for new methods. And I think we always learn from students that you work with, and if nothing else, I've learned again and again that you can do really cool things on a 9-year-old laptop. So the music industry and the news industry has changed dramatically because of social media. News is not written in the same way, and music's not produced in the same way. And I think that clinical medicine and public health are changing. I mean, clinical medicine's already changed. I mean, now, in a lot of practices, patients go in. 2 days later, they can read all of the notes that I write about them. They can read everything. So the way we write notes probably will change a little bit. But all this information is becoming kind of going back to patients, and everything's changing, and it's all in a big part because of social media. And I think that the loss of novelty will really signal success in this field. So once it becomes no longer novel and it becomes sort of every day, I think that'll be really successful. That'll be the sign of success. Once that word novel is removed from a track, then it's that's success. But I crowdsourced this talk, at least the last slide. So Alessio said I should bring this up. And he said if he could ask for one thing, he would like to know what other people's problems are. There are all these great talks about how this project was great and maybe the limitations, but what we're really missing is what people need. Here are my problems. I need X, Y, and Z to make this work. Or here's what I'd like to do, but this is what I need. Because this problem that you're working with may have already been solved by someone else, and someone else may already have the data. And what's the worst thing that can happen if you ask somebody? They could say no. I mean, so I guess I'd encourage you to ask. All right, so I think I'm under 30 minutes, and that's it. Thank you, everybody.